Welcome to Healthy Focus, the Duke Raleigh Hospital Community Education Series.
Please join me in welcoming Dr. Christopher Boehlke.
Thank you. Let me just check to make sure everybody can hear me okay. Are we okay? All right, good. Thank you so much for that introduction. Let me be a little bit more specific. What is it that I actually specialize in? Well, the front part of the eye is the easy way to explain it. Anything on the surface of the eye, whether those are growths or degenerations, the cornea, which is the window of the eye, whether that's doing refractive surgery to decrease dependency on glasses or contact lenses, or transplanting corneas for better vision from scars or other conditions, be they genetic or degenerative in nature. I do a tremendous amount of cataract surgery utilizing a variety of intraocular implants, and I tend not to go any further than the lens part of the eye. So anything lens forward is what I specialize in. What I hope to do tonight is give you a little more information about what goes on in your eyes, specifically cataracts, what's involved in cataract surgery, what happens after cataract surgery. Hopefully somewhere along the way, answer the question, how do I know when it's time to have my cataracts removed? We'll then spend a little bit of time on red, itchy, irritated eyes, which all of us experience at one time or another, and we'll go from there. I'd like to start with just some basics here. I know going to the doctor can often be an overwhelming experience with lots of information thrown at you in short periods of time. And so what I hope to do here is clarify a little bit about what happens in the eye naturally, and then what happens in the eye and to your vision as you develop a cataract. Okay? So starting with some basics about how the eye works. Let me just make sure I have my pointer here. So the goal of the front part of the eye that I specialize in, be it whether the cornea, the window, or the lens, this part right here, is to actually focus the light to a point on the retina. The retina is the part of the eye that then sends that message to the brain to be interpreted into an image that we then can see. There are a variety of glasses prescriptions. All of you wearing glasses know that there are some pluses and minuses and numbers that go associated with the glasses prescription. Myopia, or nearsightedness, is typically that minus prescription. What that means is that the light, as it enters the eye, actually comes to a focus in front of the retina. And that's either because the cornea and or lens are bending it too much, or the eye is actually too long. It can be either or. But the end result is that the light comes to a point in front of the retina and you don't see clearly. Hyperopia, or farsightedness, is just the opposite. The light comes to a point behind the retina because either the focusing mechanism of the eye, the lens and the cornea, are too weak, or the eye is too short. Astigmatism. Everybody is mystified by astigmatism, but here's the simplest way to think about astigmatism. You have a baseball or a basketball as the typical ball that I use as an example. If you cut that baseball in half, it's a sphere. Astigmatism, if you think about the word, astigma, A is without stigma, a point. There is no point of light being focused on the retina because rather than being spherical in nature, the cornea, or the window of the eye, is actually shaped like a football, where it's steeper in this direction and it's flatter in this direction, and that bends the light to multiple points in actually a blur circle, either in front of or behind, but not on the retina. Emetropia is the natural state of light focused on the retina, and presbyopia is that which happens to all of us as we enter our 40s, and regardless of whether you're nearsighted or farsighted, something happens to the focusing mechanism inside the eye, and we really don't know what that is. Whether that's atrophy of a muscle that helps the lens change shape, or whether that's just a progressive change in the rigidity of the lens itself that is no longer able to change shape. The result is that between the age of 40 and 60, we lose the ability to focus up close. And that's where the reading glasses or the bifocals come in, and that's called presbyopia. So what we do with glasses and contact lenses is simply bend the light in order to get it focused back onto the retina so that you can see clearly. And that's great. And that's where refractive surgery comes in. So LASIK and PRK, things like that, are simply treating the cornea to get the light bent onto the retina so that you can see clearly. Cataract, however, means that the lens of the eye, which we pointed out is right inside the eye here, is becoming cloudy, we'll say, for lack of a better description. The result is that light, rather than entering into the eye and coming to a nice point on the retina, is scattered inside the eye. And images and vision, rather than being crisp and clear, end up blurry to some degree. Whether that's just a simple blur like that, or glare, or halos, other symptoms we'll discuss a little bit further, because there are a variety of symptoms associated with cataract. Some of them being cloudy or dim vision, nighttime vision, need for additional light when reading. Sometimes it's sensitivity to light as you go out, even during the day in the bright sunlight. Sometimes light gets scattered through the opacities in that lens and it makes it hard to keep your eyes open. Halos at nighttime, glare when driving at night. These are very common symptoms of particular kinds of cataracts. Sometimes it's just frequent changes in your glasses prescription. When you notice that, for 20 years I've had pretty much the same glasses prescription, but suddenly every few months I seem to need an update to my glasses prescription. I'm not sure what's going on here. Sometimes that's just cataract. Double vision from a single eye. This is you close one eye and you got multiple images. That's often cataract as well. Why do I have an egg on the screen? The best analogy I can come up with in terms of what is actually happening to the lens of the eye when you develop a cataract is, what did this egg, particularly the egg white, look like prior to cataract surgery? Or prior to putting it in the pan. It was translucent. It was clear. The egg white is made of protein. The lens of the eye is pure protein. It's the highest concentration of protein in the body. When you heat an egg, you denature the proteins. You're just changing the shape of the proteins in the egg, and it becomes opaque, and light does not go through it. Same exact process is happening with the cataract. You're denaturing those proteins. It's becoming cloudy. Light cannot pass through the lens. Your vision becomes blurry. So when you think of cataracts now, you'll always think of an egg. So let's go into a little more specifics regarding the anatomy of the front part of the eye and the lens in particular. I already pointed out the cornea and the lens here. You'll see that the lens has some little strings, we'll call them, fibers. They're actually ligaments, zonules we call them, zonules that hold your cataract in a capsule. It's actually a bag. It's wrapped up in a bag called a capsule. And this is what it would look like. You've got your zonules here. You've got your capsule, the little bag. And then the outer layer of your lens is called the cortex. And the inner part of the lens is called the nucleus. And this allows us to differentiate the particular kind of cataract that you have. So a nuclear cataract is simply more or less that opacity of the fried egg or the scrambled egg, where the nucleus is becoming very dark and yellow, and the proteins are denatured, and you're not getting light through the eye, and colors seem washed out. Although what often happens is this process occurs so slowly. This is the typically slow-growing kind of cataract, and so symmetrically between the two eyes that sometimes you don't notice what you're missing until you have one eye fixed, and then suddenly, wow, oh, okay, I didn't realize blues were really blue, and the vision was supposed to be better than what it is when you have bilateral nuclear cataracts. Cortical cataracts, these typically cause your glare symptoms. You're going out in the bright sunshine, can't keep my eyes open, driving at nighttime, headlights are scattering, I'm having trouble seeing with oncoming headlights. These actually represent water vacuoles in the cortex of the lens. So these are actually, sometimes they're straight like this, radially, Sometimes they're just actual water bubbles. We call them vacuoles within the lens of the eye. But they basically have the effect of scattering light as it enters the lens. Another kind of cataract, posterior subcapsular. So this is on the posterior portion of the lens, right adjacent to and even touching that capsule that's holding the lens. This can be really rapid in progression, even within a few months. Glare, difficulty with bright lights, often reading vision is affected because this is closer to the nodal point of the eye and it tends to make it difficult to read. I mentioned in contact with this capsule often can leave behind some scar tissue or contribute to scar tissue formation following your cataract surgery, which we will touch upon a little bit later. But yet another flavor or kind of cataract that can develop in the lens of the eye. So what causes a cataract? Why do some people have cataracts at age 30? And yes, I do cataract surgery on 30 and 40-year-olds every week. And some people go until their 80s or 90s before they have cataract surgery. The honest answer is we have no idea. And like everything, there's many factors involved. Some of it is genetics. Some of it is environmental exposures to ultraviolet radiation, no doubt. Smoking perhaps contributes. High levels of oxidants, which is why antioxidant therapy comes into play with vitamins and supplements. We'll talk about a little bit later. So many things contribute, but the longer you live, the more likely you are to have visually significant cataract. A family history of earlier cataract is certainly likely to contribute to earlier progression of your cataracts. Diabetes, no question, uncontrolled diabetes will contribute to severe cataracts very early in age. Oftentimes those posterior, subcapsular, or cortical cataracts develop in the presence of out-of-control diabetes. Obviously injury or trauma to the eye, inflammation in the eye. Steroid use, whether those are steroid eye drops, which we often use. I write for lots of steroid eye drops, or usually systemic steroids used long-term can contribute to posterior subcapsular cataract formation. And again, exposure to UV radiation, certainly there's some component to that as well. So how long have we been doing cataract surgery? Well, there are records to show that long ago, even in ancient Egypt, people were doing a procedure we called couching, where when the cataract became so dense that light wouldn't even enter the eye, they would actually just push it into the back of the eye with a needle. It sounds crude, but if you go from no light at all to suddenly light enters the eye, and even though you don't have a lens anymore, you can get around, that was a huge improvement. And so that was primitive cataract surgery. We're a whole lot better at it now, for sure. But I want to take a little detour here and tell you about Harold Ridley, because I think this is a fascinating story, and I highly recommend this book if you're interested in the subject. Dr. Apple recently passed away, but he was world's authority on intraocular lenses and cataract surgery. What we'll get to in just a second is that as part of cataract surgery, what we're doing is removing that cloudy lens from the eye and then replacing it with a lens implant. And that lens implant is what allows us to address both the cataract and sometimes your nearsightedness, farsightedness, or astigmatism. Because we put power into the implant, and the implant is specifically measured for your eyes. So how do we figure out implants? Where did implants come from? Well, Sir Harold Ridley was an ophthalmologist in the UK, and during World War II, he worked with fighter pilots. And he noticed something remarkable. The pilots would sometimes come back with bits of the cockpit embedded in their eyes, the canopy embedded in their eyes, and they didn't cause any reaction from the eye itself. He realized that it was an inert material. That was polymethyl methacrylate, or plexiglass, basically. The hockey arenas have the plexiglass around it. So his observation was that, wow, PMMA cockpit material isn't causing any problems when it's inside an eye. Well, wow, what if we make a PMMA implant, take a cataract out and put an implant made of PMMA back into the eye? And that's what he did for the first time in 1949. He took it out a few weeks later, but that started the whole trend of cataract surgery and intraocular lenses being used to replace the natural lens of the eye that has become cloudy. So remarkable story. We still use PMMA implants, but we tend not to favor them because they're rigid plastic. And it means we have to make a really big incision to put them in. And as we'll talk about in just a minute, we now use implants that are moldable, soft. We can fold them up and put them through a 2mm incision. So a lot of progress made there. So what happens when you come to have cataract surgery? Well, number one, it's an outpatient procedure. You don't go to sleep typically. You get some I don't care medicine in your IV so that it's not a traumatic experience. And what the surgeon does is remove the cloudy lens of your eye and replace it with an implant. It used to be that the lens itself was removed in its entirety. Extracapsular cataract extraction through a large incision. We still do a variant of this today. Outside of the United States, extracapsular cataract extraction is very, very popular, very economic, very successful. We don't do it this old way anymore simply because of the recovery time, the invasiveness, the large incision that's required. So what we use now, and what every cataract surgeon uses for the most part now, is called phacoemulsification. Phaco referring to the lens, emulsification basically using an ultrasound probe to emulsify that lens and then draw it out of the eye into tiny, tiny little bits. And like I said, that's done through very small incisions, anywhere from 1.8 to 2.6 millimeters in size through the periphery of the cornea. The new lens is then placed into the eye. As you can see here, this is a small, about 2mm incision. There's a cartridge here with the implant that's folded up in the cartridge. This is the capsule that's been opened. You can see this inner circle. The cataract has already been removed, and the implant is going into the eye. There are multiple steps here involved. As we said, there are different layers to the lens. There's the cortex, there's the nucleus, but basically it starts with a small incision through the periphery of the cornea. You get lots of dilating drops at the beginning because we've got to get your pupil big to get access to the lens, which is behind the pupil. We open up the front of this capsule, like we said. You saw that circle in the last slide. We use a phacoemulsification probe to emulsify the lens, an aspiration probe to remove the cortex. We implant the lens through this small cartridge, and we open it back up, position it back into the natural capsule or bag of the eye. Over the next 6 weeks or so, that capsule shrink wraps around the implant and stabilizes it and prevents it from moving. What your glasses prescription is following cataract surgery depends fully on where this implant comes to rest inside the eye once the capsule has scarred. And that's why typically after cataract surgery, you won't get a new glasses prescription for 4 to 6 weeks, because that capsule takes that long to scar, and the implant will subtly change position in that healing time. Likewise, when we measure your eyes in preparation for cataract surgery, we're taking detailed measurements of the diameter, the length of the eye, front to back, the shape of your cornea, all these different measurements, trying to guesstimate, and I use that term, guesstimate, where that lens is going to come to rest in the eye, because that will determine your glasses prescription afterwards. We're pretty good at it, but we're not as good as we think we are. And so when you hear your cataract surgeon tell you, I'm going to give you 20/20 distance vision when we're done. I promise 20/20 distance vision when we're done. Be skeptical. Because while we do pretty well there's always a chance that you may end up a little nearsighted, a little farsighted, a little tilt, which will cause some astigmatism. It is a guesstimate in terms of where is that lens coming to rest, so there is a little bit of inherent uncertainty. Like I said, we're doing really well. We're going to do even better in the future as our ability to measure eyes gets better, as our ability to do cataract surgery gets better. Those outcomes will continue to improve as well. I did mention variety of implants, that I do use a variety of implants. I'm not going to spend a lot of time talking about these implants, but monofocal simply means that when you're done, you have one focal point. And typically, it's an individualized decision as to whether or not you want that focal point across the room. So you'll potentially be able to drive without glasses, or whether you want a focal point to read. That tends to be the biggest decision, and there isn't a across-the-board rule that everybody goes one way or the other, because a lot of patients who have spent their lives reading right here comfortably without their glasses, if you suddenly take that away and give them vision across the room and the need to put glasses on to read, they're going to be really unhappy. And so it's really an individualized process that I go through with each and every patient to, number one, analyze where are you coming from? What has your prescription been your whole life? What do you wear glasses for now? What do you hope not to wear glasses for following cataract surgery? And then we make an individualized decision as to what we're going to do in terms of a refractive target, distance near one of each, so on and so forth, with the cataract surgery. A toric implant fixes astigmatism. As I mentioned, astigmatism is just a change in the shape of the cornea. There are different kinds of astigmatism. So I'm not referring to all kinds of astigmatism. Astigmatism that is regular is very successfully treated with glasses. If you have regular astigmatism that's very well fixed with your glasses, you might be a great candidate for a toric implant that would help reduce the amount of astigmatism that you have following cataract surgery. Presbyopia correcting implants try to reduce your dependency on all glasses. It is developing technology, excellent for certain patients, not excellent across the board. I use these lenses very selectively. What they're doing basically is taking a little bit of the quality of your distance vision in order to give you some improved vision up close without the need for glasses. Are they better lenses? No. Do they give you better vision? I don't think so. Might they decrease your dependency on glasses? Maybe. Maybe. So we'll leave it at that. Okay. Post-operative care. Following cataract surgery, recovery is pretty quick. People are back to life pretty close to normal even a couple of days later. There are multiple visits and some eye drops for a few weeks. A little bit of discomfort, scratchy sensation in the eye. The day of surgery is pretty normal. The vision really takes a couple of days to settle in. And after a week, I pretty much release patients to go back to life unrestricted, totally normal. I mentioned some scarring or need for additional attention with a certain kind of cataract, the posterior subcapsular cataract. Now, cataracts don't come back. Once you've removed the lens of the eye, it never grows back. But the capsule is still there. And the capsule is what used to hold the lens. There are always going to be microscopic lens cells left on that capsule when we're done with the cataract surgery. But we want the capsule there because it's holding the implant. So what happens quite frequently, and not uncommonly, is that the capsule can become cloudy. And from the patient's perspective, it seems like you're getting your cataracts back. Your vision gets cloudy again, you get the glare halos, you're not sure what's going on. It's posterior capsular opacification. It can happen anywhere from the day after surgery, the surgeon tells you, you know what, you've got some scar tissue there, we'll need to laser that in a few months, to years down the road it can develop. Fortunately, there's a pretty straightforward solution.
You're saying that this can be corrected?
Yes. Yes. When this happens, there is an in-the-office laser procedure that takes literally about 3 minutes to perform, whereby we use a laser to basically open up that posterior capsule. So when you're done, you have a capsule that's scarred around your implant, with an opening in the front of the capsule that was made during your cataract surgery, and an opening in the posterior part of the capsule that was made with a laser following the development of the posterior capsular opacity. So I'm going to transition a little bit from cataract surgery now, but I'm going to go back. I'm going to finish by addressing the question I posed at the beginning. How do you know when it's time to have your cataracts removed? Well, it's a combination of factors. If you feel like your vision has deteriorated or is not to the same quality as it used to be with your best pair of glasses or contact lenses on, see your eye doctor, have them measure your vision, have them look at your cataracts, talk to them. There are certainly some requirements in terms of what's appropriate to operate on, but the trend, at least for now, is patient symptom-driven decision-making. How bothered are you by your vision? Is there cataract present to explain those visual symptoms? Are we quite confident that your vision will improve with cataract surgery? Likely appropriate to proceed with a thorough understanding of the risks involved. Okay, I'm going to leave it at that. Let's move to red, irritated eyes. Okay? Everybody at one time or another has red, irritated, itchy, bothersome eyes. It does not mean that you reach for Visine. Okay? Visine is available. It's great for certain things, but all Visine does is constrict the blood vessels on the surface of the eye and make them smaller. The more you use it, the more dependent you become on it, and the bigger the blood vessels get when you're not using it. So it actually breeds dependence and isn't the best. So let's figure out what's causing red, irritated eyes. And first, a disclaimer. Redness, so a party invitation, RSVP. Unfortunately, it's an overused and nobody responds anymore. But redness, sensitivity to light, vision changes, and pain. This constellation of symptoms together are problematic for me. If you have redness together with sensitivity to light, meaning you're having a hard time keeping your eye open, even in ambient light conditions, you're getting blurry vision at the same time, and painful, gotta see somebody. Those are warning signs that something serious is going on, whether it's an infection or inflammation in the eye, something that needs further attention. Okay? Allergic conjunctivitis. A lot of people have allergies. Do allergies cause eye irritation? Certainly. Certainly. Typically, though, I think it tends to be a little bit overdiagnosed. Yeah, I think it's the wastebasket diagnosis. You've got red, itchy eyes, it must be allergy. I mean, I have lots of patients that come in and say, my eyes are red and irritated, or red eyes must be allergy. And sure, sometimes it is, but a lot of times it isn't. Allergy tends to be itchy. Mosquito bite kind of itchy. Oftentimes corner of the eye. It can be one eye, it can be both eyes. Itchy, like you want to scratch it like a mosquito bite. If that's the case, you want to start with some oral antihistamines. You know, even over the counter these days, you can get Claritin, Zyrtec, things like that. Topical antihistamines. There are eye drops at the pharmacy on the shelf that used to be by prescription. There are antihistamines, mast cell stabilizers. These are anti-allergy drops that you can certainly try. I often recommend that you try an artificial teardrop that you put in the refrigerator, so that chilled drop has a soothing effect on the surface of the eye. And if you're quite convinced that you have systemic allergies, or you know you get into bed every night and you've got your down pillow and it causes your eyes to itch, you remove the offending substances, you talk to an allergist, you consider immunotherapy to get that allergic reaction under control. Okay? Dysfunctional tear syndrome. That's our fancy term for dry eyes. Okay? I just put this up here to kind of demonstrate how complicated dry eye or dysfunctional tear syndrome is, how multifactorial it is. But let me simplify it for you just a little bit. When we think about dry eyes, we think about not enough water, not enough tearing, or we think about too rapid evaporation of the tears that are present in sufficient amount They just don't sit on the surface of the eye long enough to keep it coated. So we talked about aqueous or water deficient versus evaporative dry eye. Okay? Blepharitis. Hugely present. Many people have blepharitis. This is the eyelid. Bleph refers to the eyelids, itis, the inflammation of the eyelids. And we tend to distinguish between the front part of the eyelid, anterior blepharitis, and posterior blepharitis. Anterior, the crusty eyelashes, the debris at the base of the eyelashes. Posterior blepharitis, what this is a picture of, they're called the meibomian glands. Each eyelid has 30 to 35 glands whose job it is to create part of the tear film. And it's that part of the tear film that prevents the tears from evaporating. And so when the glands look like this, and you press on them, they look like toothpaste, and the lids are red and inflamed, oftentimes the tear film is of very poor quality, and the eyes get dry as the day goes on. Anterior blepharitis can cause similar symptoms, but tends to be more of the gunky, crusty eyelashes, not so significant in terms of effects on dry eye, but certainly can cause irritation and redness. I'm going to start with inflammation, because inflammation along the eyelid margins can be tremendously symptomatic. Why do we get inflammation along the eyelid margins? That's a great question. Oftentimes, if you have a skin condition where there are superficial blood vessels on the cheeks or on the noses, and sometimes not so much on the cheeks or noses, but on the eyelid margins, these blood vessels can leak inflammatory mediators that then somehow cause these glands to get all plugged up and inflamed. That then leads to the dry eye, but it can also cause tremendous amounts of inflammation to sit on the ocular surface, particularly overnight when you're sleeping. And so one of the questions I often ask my patients when they come in for a dry eye evaluation is, how do your eyes feel when you wake up first thing in the morning? If they say, oh, that's the worst time of day, my eyes are burning, irritated, sometimes there's mucus, I look at the lids, if I see anything like that, it's evaporative dry eye with posterior blepharitis. I shouldn't have said evaporative dry eye. It is, but that's what affects them toward the end of the day. In the morning, it's the inflammation from the eyelids and these meibomian glands that they're really noticing. And toward the end of the day, it's that poor quality tear film that's causing the surface of their corneas to get very dry. And then that's in addition to what's going on earlier in the day. So what can you do at home to help with these things? And what do we do in the office to help with these conditions? First off, I should say that this tends not to go away. If you have this, you're probably always going to have this. And what we do when you come in for an evaluation with us is tell you, we're going to just make it so that it doesn't bother you as much, but I'm unlikely to make it go away. And what I typically see is I can give you medications, I can give you things to do that will make things better. It'll stay quiet, not bother you for months to years, but it will flare. It will come back and bother you at some point in the time, and then we'll go through the same process of treating it and calming it down. This sort of anterior blepharitis is where you've heard the eyelid scrubs or the baby shampoos or the OcuSoft lid scrubs. Just taking a little baby shampoo, either straight out of the bottle or diluted in a little bit of water, and just cleaning your eyelashes a couple times a week. I have young kids, so it's always right there. I just take it and scrub my eyelids every day, or a couple times a week, and that just decreases the buildup on the eyelashes, decreases the debris, things like that can help just the quality of the surface of the lids. The posterior blepharitis, or meibomian gland dysfunction, is where warm compresses come into play. This is where I recommend patients take a washcloth under really quite warm water, about as warm as you can tolerate on the very thin skin of the eyelid, and spend a good 3 to 5 minutes each night as part of your getting ready for bed regimen, just literally soaking and heating up those eyelids with the goal of, number one, perhaps opening up those glands a little bit, number two, perhaps liquefying some of the secretions that are in those glands, And then with some manual expression, using your finger to really put some pressure on those glands and see if you can secrete them, try to get that meibum moving again so that you've got less inflammation, less plugging in, a healthier tear film. When you come to the office with really bad meibomian gland dysfunction, what we'll often do is either put you on topical steroids, which you don't want to use long term but can be tremendously helpful in the short term to calm something like this, or antibiotics, both topical and even oral antibiotics, and not necessarily because you have an infection, but because certain antibiotics have very good anti-inflammatory properties. So for example, there is a topical antibiotic that we use quite frequently that has nice anti-inflammatory properties, and rather than send patients out with topical steroids to use for their blepharitis long term, a safe topical antibiotic without the side effects of steroid would be my first choice. Oral antibiotics, the tetracycline, doxycycline, minocycline class of antibiotics, if you were to go to the dermatologist with real bad rosacea, they'd be the same class of antibiotics that they'd give you there, have very good anti-inflammatory properties. Oftentimes we'll do several months at a time of oral antibiotics to help calm what's going on in these glands and in the eyelids. Supplements are always interesting from my perspective because I always want to make sure before I recommend patients go out and spend money on supplements that there's decent science to support the use of supplements. Omega-3 fatty acid supplementation, whether that's flaxseed oil or fish oil, pretty decent evidence that it's going to help you overall, and actually some good evidence that it will help eyelid inflammation too. And so when I've kind of exhausted all of my treatment options for blepharitis, we've used steroids, we've gotten through some topical and or oral antibiotics, I'll always recommend omega-3 fatty acid supplementation. It doesn't matter so much what it is. Yes, there are prescription omega-3 fatty acids, but you can go to your local pharmacy and or Whole Foods or wherever and get flaxseed oil or probably better fish oils. But that's something easy that you can do in addition to warm compresses, a little bit of lid scrubs periodically. And then I should mention too, artificial tears is part of this treatment as well during the day, in part because the teardrop, even if you're not dry, will help decrease the inflammatory load on the surface of the eye. Just putting a drop on the surface of the eye will help dilute the inflammation. And so even if you're not dry, I will always recommend artificial tear use on a regular basis, 2, 3, 4 times a day if I'm seeing you for severe conditions like this. Well, let's talk more dry eye symptoms. I mean, dry eye is very, very difficult, very multifactorial, and can be tremendously different in symptomatology from patient to patient. Sometimes it's the stinging, burning, scratching. Sometimes it's the mucus. Sometimes it's irritation out at work, or when you go to the mall. That's a really common scenario. You go to the mall with that blowing air, and you feel like you can't keep your eyes open. Again, sensitivity to light, eye fatigue or eye strain. I hear it every day. I think my eyes are strained. I'm using the computer too much. What is eye strain? It's dry eyes. The computers aren't doing anything to us. There's no literature to suggest that monitors are emitting something that's damaging our vision. You're focused on a computer monitor. You're focused on reading your book. You're not blinking as often as you usually do. The surface of your cornea is getting dry. That's really, really common. Eye fatigue, your eyes, the default position for your eyes is on. From the minute you open them in the morning, they're on and they're working. The only thing that changes is your brain. What are you paying attention to? I'm reading now. I'm paying attention to this. I'm not blinking as often. I'm driving. I don't want to miss something. I'm not going to blink. Eyes are always working. They don't get fatigued for the most part. Tearing, that's another thing. I often tell patients, you're dry. But doc, my eyes are tearing. They're wet. Yes, because they're dry. It's a reflex tearing response, right? Your eyes get dry. There's a feedback loop. It tells your lacrimal gland or your other glands that you need more moisture. However, that reflex tear isn't the same quality as the tear that's supposed to lubricate the surface of the cornea. And so you get this tearing response. Sometimes it even runs down your cheek. That's a slightly different condition where the eyelids become involved. But you're tearing because you're dry. And so again, that's where adding tears doesn't seem to make sense, but it is the appropriate thing to do. And then blurred vision, fatigue at the end of the day, feeling like you need to close your eyes. I mean, those are symptoms of dryness. So what do we do to treat dry eye? Well, eyelids, number one, pay attention to the eyelids. I mentioned the distinction between aqueous deficient and evaporative dry eye. 10 years ago, a cornea specialist standing here would have focused on aqueous deficient dry eye. That was the rage. Everybody had aqueous deficient dry eye. You know, there were some prescription medicines that would help with that. What we realize now is most people produce enough aqueous component of their tear film. Most people have enough water component to the tear film. But way more people have evaporative dry eye, where these glands aren't functioning, where the tear is present, but it doesn't stay on the surface of the eye. So managing eyelid health across the board for my dry eye patients, we address that. No question at all. Drying medications. So, like I said, multifactorial. There are many, many systemic medications that can contribute to severe dry eyes. And so when I see a patient for a dry eye eval, one of the things I'm doing is going through their list of medications. You know, lots of categories of medications that have drying effects. A lot of them you can't stop. Some of them you can. One scenario, just as an example, oral contraceptives. When I have younger women coming in for dry eye evaluations, if I notice they're on an oral contraceptive, I'll talk to them about stopping it or changing it. Hormonal changes in the body can have a tremendous effect on dry eye. The other systemic medications that you take can certainly affect dry eyes. So eliminating other medications, I didn't add it here, but other environmental factors also need to be eliminated. If you sleep with a fan on at nighttime, turn it off. I bet you'll notice an improvement in your symptoms. If your computer monitor is positioned up rather than straight ahead or down slightly, you're opening your eyes more than you need to. Change that position. Pay attention to these subtle things that can have effect on dry eye. Add tears. Well, that makes sense. Quick question?
Yes, I just wondered if you could explain what is the process of tearing when you have a very, let's say, strong emotional experience? Like, you know, a lot of us.
That's a good question.
Ex-service, we've witnessed a lot of things. Sometimes you see that and you tear because you're sensitive to that.
Yeah, I mean that's an excellent question, because that's routing signals through a different part of the brain that carries emotional content and sending a signal to the lacrimal gland to produce a tear for a reason we don't know. That's a great question, but different than a dry eye tear or a tear that's deficient in dry eye. But excellent question. Excellent question. Adding tears. Over-the-counter eye drops is where you start. You know, you go to any pharmacy, any drugstore, grocery store, there's always an aisle full of tears. Again, Visine is not necessarily the answer, nor am I endorsing necessarily these brands, but what I wanted to show here is just the distinction between anything that comes in a bottle and anything that comes in, or most things that come in a clear vial like this. The biggest difference being preserved with a chemical, no preservative. Okay? Anything in a bottle, no more than 4 or 5 times a day, tops. And for some people, well, no way can I put a drop in that often. But for really severe dry eye patients, I sometimes have them come in using a bottle drop like this 10 or 12 times a day. And guess what's causing a lot of their problems? That bottle drop. And so the first thing I do is say, stop all of your drops, come back and see me in a couple of weeks, and let's see how you're doing. And oftentimes that helps in the correct scenario. So bottle drop is great if you're going to use it 3 or 4 times a day, no more. Preservative-free drops have no chemical preservative, shouldn't irritate the surface of the eye. Now, of course, I can't say that across the board, but shouldn't irritate the eye. Can typically use them about as often as you want. Conserve tears. So what happens to our tears naturally when they move from the surface of the eye? Why does my nose run when my ears, or when I'm crying, or when I've got an irritant in my eye? It's because there are little holes in the corner of our eyelids. And that's where our tears are supposed to drain into our nose naturally. We can close those little holes with something called punctal plugs. We can even close them surgically to conserve tears on the surface of the eyes. That's a very common strategy to help dry eye patients. Can be very helpful, but can also make some patients worse. So sometimes I have patients coming in for dry eye blepharitis evaluations where I actually remove the punctal plugs because the eyelid inflammation has not been addressed. The punctal plugs have been placed. The eyes become more red and irritated because that inflammation is now sitting on the surface of the eye with nowhere to go. Take the plugs out, things drain more, tears dilute the inflammation, maybe a little topical steroid, and things are better. So punctal plugs typically in my regimen come after the inflammatory treatment of dry eye and or lid disease, meaning tears, maybe a little mild steroid. Make sure the eyelids aren't going to make the surface of the eye much more inflamed when suddenly those tears can't leave the surface of the eye. And again, we come back to omega-3 fatty acids. Okay, evidence that that's going to help. Quick question.
What if you have a clogged tear duct and why are dry eyes bad for you? Like, what is it doing? How is it damaging your eyes? Like, if you don't put it on drops in or do something to take care of it?
Excellent question. I'll address that. If you're not bothered, it's unlikely to cause much problem at all. Most of this is symptomatic, meaning my eyes are bothersome, they don't feel right, my vision blurs very quickly. In the absence of those symptoms, it's unlikely to have any permanent change to the cornea. Scarring, problems independent from that. Typically, it's a symptomatic management where no damage typically is done long-term in those scenarios. There are exceptions, however. Some patients don't have normal sensation, can't sense that any damage is being done, but for the most part, none. Surgical treatment of dry eyes. Okay, there are a couple of newer technologies out there that are showing some promise in terms of treating dry eye. One of them is called LipiFlow, which is a technology Duke has had for about a year. You remember I said warm, moist compresses on the outside of the eyelids. What this is an in-the-office treatment heating the eyelids from the inside. So there's a heating element that's placed inside the eyelids with a shield over the cornea that theoretically heats up those meibomian glands, helps to liquefy those secretions, and then this actually puts some pressure on those glands with the idea that over about 15 minutes you're going to get some heating, massage, and expression of those meibomian glands to help produce a healthier tear film and decrease your dry eye symptoms. Intense pulsed light therapy is another surgical treatment for some of this. I mentioned rosacea, the abnormal blood vessels that can leak inflammatory mediators. What this does is address those abnormal blood vessels with a treatment that will hopefully, reduce the inflammatory mediators that contribute to the plugging of these glands that then can cause inflammation and the dry eye symptoms. Both of these are, like I said, developing technologies that show promise for certain patients. So vitamins and supplements, and what else can you do at home? Apart from the eyelid hygiene artificial tears, which is really, really easy. We talked about omega-3 fatty acids a couple of times already. AREDS vitamins for macular degeneration. Now this is out of my area of specialty, but I am an eye doctor. I do look at the retina. I do see lots of macular degeneration. AREDS stands for Age-Related Eye Disease Study. There was a study of patients, big group of patients. There's actually a second study being done currently. With patients that had macular degeneration who were given a combination of vitamin C, E, zinc, copper, and beta-carotene, basically antioxidants, and it was shown to decrease the rate of progression of macular degeneration for certain patients. So we have pretty good evidence to say that the AREDS vitamins are worth taking if you have a certain degree of macular degeneration. Now, some doctors say just give it to all patients with macular degeneration. Yeah, I guess you could, but I tend to feel like if you don't have the criteria that were studied in the actual study, stick with a balanced diet. Don't smoke. Limit your oxidant exposure as much as you can. Zeaxanthine and lutein, these are antioxidants that are marketed very aggressively in vitamins these days. Promotes eye health. That's the common slogan with these. They are antioxidants. There is some evidence that in patients with really aggressive free radical activity, that's the oxidation process, the chemical reaction that occurs, maybe antioxidant therapy could slow, specifically zeaxanthin and lutein, could slow macular degeneration and or cataract progression, but that evidence is pretty weak. So I tend not to recommend, specifically zeaxanthin and lutein. I love eating good food. I'm a huge proponent of we are what we eat. I have 2 young kids, and we eat kale and spinach a couple of times a week. I think watching what you eat, eating green leafy vegetables, eating your carrots. Yes, there is some science behind eating the carrots. The molecular chemical reaction that occurs in the retina, the back part of the eye, to process that light signal and send the electrical message to the brain is dependent upon the beta-carotene in the orange carrots, the orange sweet potatoes, things like that. So there is some science behind that. That is super important. Diet, I think is tremendously important. And believe it or not, I've spent an hour talking. So I appreciate your attention, and thank you all for coming tonight.